Welcome back to Uncovering Bailey in Love with Snazzy Surgeon. Ready for another deep dive?
Absolutely. Always ready to explore the depths of surgical knowledge.
Today, we're tackling something I think every surgeon out there grapples with: the complexities of hereditary and familial breast cancer.
Definitely a topic we encounter regularly in practice.
And it's not just about having a family history, right? There's a lot more nuance to it.
Precisely. We need to clearly distinguish between the two main categories. Hereditary breast cancer, where we have those identifiable genetic mutations, often impacting multiple close relatives, passed down through generations.
Right.
And then there's familial breast cancer. We see a clustering of cases in a family, but we haven't yet pinpointed a specific genetic cause.
Makes sense. So both involve family history, but that confirmed genetic mutation is the key difference in those hereditary cases.
Right.
And, thinking about how often this comes up, the numbers really highlight why it's so crucial for us to have a strong grasp on this.
Yeah.
Hereditary breast cancer, we're looking at about 5 to 10% of all breast cancers we see.
Yeah, that's a significant number. But then when you look at familial breast cancer,
It jumps way up, doesn't it?
it does. It makes up a much larger proportion, somewhere between 20 and 30%. So we're dealing with a substantial portion of our patients where familial factors are definitely at play.
It's a huge chunk of our patient population. So recognizing those hereditary cases early on is critical.
It is. And one thing that really stands out to me is how hereditary breast cancers often present differently compared to those sporadic cases we see.
Right. How so?
Well, in my experience, these hereditary cancers tend to be more aggressive. We often see them in younger women, significantly younger than the typical age of diagnosis.
And that right there, a younger patient with an aggressive tumor, especially with a strong family history, that's a huge red flag for me.
Agreed. It definitely raises the suspicion of a potential hereditary component.
Absolutely. And from a surgical perspective, one of the things that jumps out at me is the increased likelihood of multicentricity.
Multiple tumors within the same breast?
Exactly. And bilaterality, too,
Yeah.
affecting both breasts.
That definitely influences our surgical approach.
It does. It changes the entire conversation we have with patients about their options, the potential need for more extensive surgery.
Right, right. So those clinical features, along with a compelling family history, should really prompt us to dig deeper. Consider the possibility of an underlying genetic predisposition.
Makes sense. And when we talk about hereditary cases, it's those high-penetrance genetic mutations that carry the most weight in terms of increased cancer risk, right?
Exactly.
Okay. So let's break down those key players.
Sure.
BRCA1, probably the gene we discuss most often in this context.
Yeah, it's a big one.
Located on chromosome 17q21, and lifetime risk of breast cancer associated with the BRCA1 mutation, it's substantial, anywhere from 50 to 85%.
A significant risk. And we can't forget about the increased risk of ovarian cancer as well.
Right, up to 40%.
Yeah. You know, what I find particularly relevant from a surgical standpoint is the strong link between BRCA1 mutations and triple-negative breast cancer.
Oh, definitely.
That subtype can be more challenging to treat, as we know, because it lacks the estrogen, progesterone, and HER2 receptors that we often target with our therapies.
Right, so identifying a BRCA1 mutation, it doesn't just impact our surgical decisions, it also significantly influences our adjuvant treatment consideration.
Absolutely.
And we have BRCA2 on chromosome 13q12.3. Still carries a high lifetime risk of breast cancer.
Yes, it does. Somewhere around 50 to 60%.
The ovarian cancer risk seems to be a bit lower than with BRCA1, though.
It is, yeah, around 20%. But what's really noteworthy about BRCA2 is that it's not limited to just breast and ovarian cancer risk.
It's involved in a wider range of cancers, right?
It is. We see an increased risk of prostate cancer, colon cancer, gallbladder, bile duct, even stomach and pancreatic cancers. And we also see BRCA2 mutations more frequently in cases of male breast cancer.
Which is a reminder that, while less common, male breast cancer should always make us think about a possible hereditary predisposition.
Absolutely.
So when we're taking a family history, we need to keep that broader cancer spectrum associated with BRCA2 in mind.
We do.
It's not just about the immediate breast cancer risk for the patient in front of us. It's about the potential long-term risks for other cancers, for both the patient and their family member.
I completely agree.
Now, moving beyond BRCA1 and 2,
Yeah.
we do encounter other syndromes, though less common, that contribute to hereditary breast cancer risk.
We do. They're less frequent, but still important to recognize.
What are some of the key ones that come to mind?
Well, there's Li-Fraumeni syndrome, for instance.
Li-Fraumeni.
Yeah. This one is associated with a high risk of various cancers, often starting in childhood, and breast cancer is one of them.
I see.
Then you have Cowden syndrome.
Cowden syndrome.
Yes, we often see hamartomas in these patients, and they have an increased risk of several cancers, including thyroid, breast, and endometrial. And then there's Peutz-Jeghers syndrome, which is characterized by those polyps in the gastrointestinal tract.
GI polyps.
Exactly. And it carries an increased risk of various cancers, including breast cancer.
Interesting.
And we can't forget about hereditary diffuse gastric cancer syndrome.
Right, which also increases the risk of lobular breast cancer.
It does. So while these syndromes may not be as common as BRCA1 and 2, recognizing their clinical features is really important. It can guide us towards more comprehensive genetic evaluations for our patients.
Okay, so I've got a good grasp on those genetic underpinnings now. The big question becomes, when should we be seriously considering genetic risk evaluation and referral for testing? What are those red flags in our clinic that should make us think, this patient might really benefit from genetic counseling?
Well, the most straightforward scenario is if there's a known pathogenic or likely pathogenic variant in a cancer susceptibility gene in the family.
So if we know a specific mutation runs in the family.
Exactly. Regardless of the patient's age, that's a clear indication for testing. It's all about identifying other family members who might be carrying that same mutation.
Makes sense. What are some other clinical situations that should raise our suspicion?
Early onset breast cancer. That's a huge red flag. We're talking a diagnosis of invasive breast cancer at age 50 or younger.
50 or younger.
Yes. That should definitely prompt consideration for genetic testing. And similarly, if we see triple-negative breast cancer diagnosed in a woman aged 60 or younger, that also warrants strong consideration.
Because of that connection with BRCA1 mutations.
Exactly. The age of diagnosis really plays a critical role here.
Now, what about patients who have had breast cancer more than once?
Ah, yes. If a patient has been diagnosed with 2 or more primary breast cancers, that's another strong indicator for genetic risk evaluation.
Because it suggests a potential underlying predisposition.
Right. It's not just a coincidence, so to speak.
Okay. And of course, we can't forget about family history.
Absolutely essential. It's a cornerstone of risk assessment.
So what aspects of family history should we be particularly concerned about?
Several things. If there's a family history of breast cancer diagnosed at age 50 or younger, especially in a first or second degree relative,
Okay.
invasive ovarian cancer at any age,
Yeah.
male breast cancer, again, at any age,
Right.
pancreatic cancer at any age, or high-grade or metastatic prostate cancer at any age. Any of those should raise a red flag.
It's not just about breast cancer in the family history.
It's not. It's about looking at that broader picture of cancer risk.
And we should also consider the cumulative effect, right?
Absolutely.
Okay.
If there's a family history of breast cancer with 2 or more affected relatives, even if they were diagnosed at older ages, that still increases the likelihood of a familial predisposition.
And as we discussed earlier, male breast cancer in the family is always a trigger for further evaluation.
It is. Any instance of male breast cancer, no matter what else is going on in the family history, should prompt a referral for genetic risk evaluation.
Got it. Now, what about when we see multiple different types of cancers in a patient or their family?
Ah, that's where recognizing patterns that suggest those broader hereditary cancer syndromes comes into play.
Okay.
For example, if we see 3 or more of these cancers, it's concerning. Breast cancer, sarcoma, adrenocortical carcinoma, brain tumors, or leukemia.
That's a lot of different cancers.
It is. Another pattern we watch for is the combination of colon, endometrial, thyroid, and kidney cancers, particularly if there are other features like skin findings or those hematomatous polyps in the GI tract that might suggest Cowden syndrome or something similar.
Right.
And then we have combinations like lobular breast cancer and diffuse gastric cancer.
Linked to CDH1 mutations.
Exactly. Or a history that includes breast cancer, gastrointestinal cancers, those hematomatous polyps again, ovarian sex cord tumors, pancreatic cancer, testicular Sertoli cell tumors, or even childhood skin pigmentation.
Wow, that's a wide range.
It is. But these patterns, they can point towards Peutz-Jeghers syndrome or other rare syndromes, so recognizing them is crucial for identifying patients who might need a more thorough genetic workup.
This is incredibly helpful. A really comprehensive overview of the indications for genetic testing. It's so important for us to have this knowledge at our fingertips when we're evaluating patients.
I agree.
Now, let's shift gears a bit. Let's say we have a patient who we know is a BRCA mutation carrier. What are the key risk reduction strategies we should be discussing with them? What can we offer?
Well, we have several powerful tools at our disposal. From a surgical standpoint, bilateral risk-reducing mastectomy with immediate reconstruction is a highly effective option.
We hear about that a lot.
We do, and for good reason. Studies have shown it can reduce the risk of developing breast cancer by a remarkable 90%.
90%. That's a huge reduction in risk.
It is, and that translates into real benefits for these women, not just in terms of survival, but also in terms of quality of life, taking away that constant fear and anxiety that comes with knowing they have an increased risk.
A peace of mind is incredibly valuable.
It is. And of course, we also need to address that elevated risk of ovarian cancer.
Right, especially with BRCA1 mutations.
Yes. So for premenopausal women who've completed their families, typically around 35 to 40 years old, we often recommend bilateral salpingo-oophorectomy.
BSO.
Exactly. It's very effective in reducing the risk of ovarian cancer, which, as we know, is often diagnosed at a later stage and carries a less favorable prognosis.
I see.
Of course, the timing of this procedure is something that needs to be carefully discussed with each patient, weighing those risk reduction benefits against the potential impact on their hormonal health and future fertility.
And it's a sensitive and important conversation.
It is.
Now, beyond surgery, what about medical strategies for risk reduction? Are there any options there?
Yes, there are. Chemoprophylaxis can be a valuable tool. We use medications like tamoxifen or anastrozole.
Tamoxifen and anastrozole.
Yes. Studies have shown that they can potentially lower the risk of developing breast cancer by about 50% in BRCA mutation carriers.
So, a significant reduction, though not as dramatic as with surgery.
Right. It's important to have an open and honest discussion with patients about the role of medical prevention, talking about the potential benefits, the limitations, and any possible side effects, so they can make an informed decision about how they want to manage their risk.
Well, we've covered a lot of ground today, really delved into the intricate world of hereditary and familial breast cancer.
We have.
We started by clarifying those definitions, talked about how common these conditions are, and highlighted the unique ways hereditary cases often present.
Right.
We dug deep into the significance of those high-penetrance genes, BRCA1 and BRCA2.
Yes.
And we discussed the essential criteria for genetic risk evaluation, along with those crucial risk reduction strategies for BRCA mutation carriers.
It's been a thorough discussion.
And it really underscores why this knowledge is so essential for all of us as surgeons. It allows us to provide the best possible care for our patients, offer them comprehensive, informed counseling, and ultimately help them navigate the challenges of having an increased risk of breast cancer due to those hereditary or familial factors.
I couldn't agree more. Understanding these nuances is absolutely essential for providing optimal and personalized care for each patient.
Well said. Thank you so much for joining me for this deep dive. I always appreciate your insights.
It's been my pleasure.
And to everyone listening, thank you for joining us. We'll see you in the next episode.
Until next time.
Thank you for listening to our podcast. See you in the next episode.